Patients here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application for
your left
hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Imagine you're like 3 hours into your night shift.
Man, the witching hour.
Right. You're on the acute psychiatric unit. And a patient, someone who literally just an hour ago looked you dead in the eye and said you are the only nurse in the entire hospital who actually cares about them, is now standing out in the hallway screaming at the top of their lungs that you are a monster.
Yep, I've been there.
They're demanding a completely new care team, telling the charge nurse you're, like, intentionally trying to harm them. And the thing is, this isn't a medication error.
No.
It's not a misunderstanding, and they aren't hallucinating either. What you are witnessing in that hallway is just the raw, unfiltered manifestation of a personality disorder.
And, you know, for a nurse who isn't prepared for that, that exact scenario can absolutely shatter your clinical confidence. I mean, it can derail the entire unit's milieu.
Because it feels so deeply personal.
Exactly. It feels like an attack. But when you really understand the mechanics behind that behavior, you realize it's actually this desperate, chaotic survival mechanism.
Which is exactly why we're here today. So welcome to a highly specialized deep dive designed specifically for you, the listener.
Think of us as your elite psychiatric nursing mentors. We are pulling you off the regular floor, we're sitting you down in the break room, and giving you the ultimate clinical survival guide.
Because the stakes in psych nursing are incredibly high. The sheer volume of information you're expected to just, synthesize for your nursing exams, your clinicals, the NCLEX, it can feel completely paralyzing.
Oh, for sure. It's overwhelming. So our mission today is absolute precision. We're operating strictly on the 80-20 rule.
Right.
We are going to extract the highest yield 20% of psychiatric nursing knowledge, specifically regarding personality disorders.
And mastering that specific core is what gives you the 80% of the understanding you actually need to dominate NCLEX-style questions and, sharpen your clinical judgment.
And most importantly, keep your patients and yourself physically and emotionally safe.
Yeah. We are bypassing the low-yield fluff today. We are explicitly targeting how to spot these disorders, the underlying pathophysiology, like why these patients act the way they do, and the absolute priority nursing assessments.
Plus the high-risk safety red flags and the specific therapeutic communication strategies you just have to use.
Okay, let's unpack this, because before we get into the weeds of borderline or antisocial behaviors, we have to establish a baseline.
Right.
What actually is a personality disorder? Because, in everyday conversation, people throw around terms like narcissist or sociopath all the time.
Oh, constantly. Usually to describe a bad boss or a toxic ex.
Exactly. But clinically, in a hospital setting, we are talking about something entirely different, right?
Completely different. I mean, clinically, a personality is defined as an ingrained, enduring pattern of behaving and relating to the self, others, and the environment.
Ingrained and enduring. Those are the key words.
Yeah, absolute operative words. We aren't talking about someone having a bad week.
Right.
Or, someone acting out because they are acutely grieving. These behaviors are consistent across a massive range of situations, and they're incredibly resistant to change.
So a personality crosses the line into a personality disorder when there is a significant pervasive impairment in how that person functions.
Right. Those traits become deeply maladaptive. They fail to conform to cultural, social, or legal norms. It essentially destroys their ability to maintain relationships or, hold a job.
And here's the major blind spot, right?
Yeah.
The thing that makes treating these patients so uniquely difficult. The egocentric nature of the disorder.
I'm really glad you brought that up, because that is a massive concept for nursing students to wrap their heads around.
Egocentric, meaning the behaviors actually align with the patient's ego.
Right. To the patient, their behavior feels completely natural. It feels justified. They're often completely unaware that their personality is the actual problem.
Wow. So they genuinely believe their distress stems from everyone else.
Exactly. The world is unfair. Their spouse is unreasonable. The nurses are incompetent. They completely lack the internal insight to see their own deeply ingrained behavior as the source of the chaos.
Which brings us to the first major NCLEX trap. I mean, the logic here is just paramount. Personality disorders are not illnesses with treatable symptoms in the traditional medical sense.
You have to completely separate this from the rest of your nursing education. It's so important.
Right, because if a patient comes in with acute bacterial pneumonia, you just administer 5E antibiotics, monitor their oxygen, and the symptoms clear up.
The problem is solved. Even with a major depressive episode, you might start them on a targeted SSRI, and within 4 to 6 weeks, the heavy fog of depression begins to lift.
But you cannot give a patient a pill that suddenly makes them empathetic.
Right.
You do not cure a personality disorder during a 3-day or even like a 3-week hospital stay.
If a patient is admitted to your acute psych unit, your goal as a nurse is not to fundamentally restructure their personality.
Right.
Because if that is your expectation, you're going to leave your shift completely burned out and furious.
So what is the goal then?
Crisis stabilization and physical safety.
Yeah.
That is it.
Just safety.
The psychiatric literature is absolutely definitive on this. No specific medication alters personality. The therapy required to help these clients make meaningful changes, like dialectical behavior therapy that takes years of intensive outpatient work.
Progress is measured in millimeters, not miles.
Exactly.
Millimeters.
Okay, so if we can't just fix it with a medication, we really need to understand how this faulty personality was built in the first place.
Right.
Like, how does someone get to a point where their fundamental way of interacting with the world is so destructive? Our clinical framework breaks the etiology down into 2 main components: biology versus the environment.
Or, formally, temperament versus character.
Temperament versus character. Let's dig into that. It's a fantastic framework for visualizing the disorder. Temperament refers to the biological processes. It's the sensation, association, and motivation that underlie how we integrate skills and habits.
So it's, for all intents and purposes, our genetic makeup.
Basically, yeah.
Yeah.
Research indicates that genetic differences account for roughly 50% of the variances in temperament traits.
Okay, let me try to build an analogy here to lock this down for everyone, because I think it really helps visualize the difference. Let's compare the human brain to a smartphone.
Oh, I like this.
So if temperament is the factory-installed operating system, the biological hardware and base code that comes preloaded before the phone ever leaves the box.
Right.
And character is the environmental software, like the apps you download over a lifetime of experiences. How does a bug in the code actually manifest as a disorder?
That is the perfect way to look at it. So let's examine that factory-installed operating system first. There are 4 genetically independent temperament traits that are pretty much hardwired by the time a kid is just 2 to 3 years old.
Wow, that early.
Yeah, and they are. Harm avoidance, novelty seeking, reward dependence, and persistence.
Let's break those down, because the combinations of these traits basically dictate how a patient's going to react to you on the floor. Let's start with harm avoidance.
Okay, so someone with high harm avoidance has a factory setting that is constantly scanning for threats. They exhibit an intense fear of uncertainty.
Like they're socially inhibited, shy with strangers.
Exactly. They fatigue easily, they're pessimistic worriers. This can result in maladaptive inhibition. They are just paralyzed by the what-ifs.
Right. And on the flip side,
someone with exceptionally low harm avoidance is carefree, energetic, optimistic. But if it's too low, they become entirely unresponsive to potential harm or danger. They take massive unwarranted risks because their brain simply doesn't register fear.
Okay, got it. Next is novelty seeking. I'm assuming this is the dopamine chasing trait, right?
Exactly. High novelty seeking means the person is quick-tempered, fiercely curious, easily bored, highly impulsive.
They constantly need new stimulation.
Right. They might be prone to sudden angry outbursts and be highly fickle in relationships. Low novelty seeking means they are slow-tempered, stoic, reflective. They can tolerate immense monotony without going crazy.
Okay, third is reward dependence. This defines how a person responds to social cues and, like, the approval of others.
Yeah. High reward dependence makes a person tender-hearted, highly sensitive, sociable, and incredibly socially dependent.
But taken to an extreme.
They become overly reliant on validation from others, to the point of adopting other people's ideas and just discarding their own identity entirely, just to be liked.
Wow. And low reward dependence.
Makes someone highly practical, tough-minded, and cold. They're completely indifferent to being alone, which can lead to severe social withdrawal and aloofness.
And finally, we have persistence.
Highly persistent people are the hardworking, ambitious overachievers. They respond to fatigue or frustration not as a sign to stop, but as a personal challenge.
They persevere even when a situation clearly dictates they should pivot or quit.
Exactly. And people with low persistence are inactive, unstable, and erratic. They just give up the moment they hit a roadblock.
So that's the operating system. Those 4 traits are the hardware. Now, what about the software? The character. The apps downloaded over a lifetime.
Character consists of the concepts about the self and the external world. It is not genetic. It develops over time as a person confronts challenges, interacts with their family, navigates their environment.
And the clinical framework highlights 3 major character traits here, right?
Yes. Self-directedness, cooperativeness, and self-transcendence.
Let me make sure I'm translating this to bedside reality. Self-directedness is essentially how responsible, reliable, and goal-oriented you are. Do you believe you control your destiny, or are you a victim of circumstance?
Spot on.
And cooperativeness is how much you see yourself as an integral part of human society. Like, are you empathic, tolerant, compassionate?
Yes, exactly.
And self-transcendence describes how you view yourself as part of the broader universe. Are you spiritual, humble, aware of things bigger than yourself?
That is exactly it. And character matures in stepwise developmental stages, from infancy all the way through late adulthood. Each stage has a specific developmental task that must be mastered.
Right, like Erickson's stages.
Yes. If a task isn't achieved, for example, if an infant is severely neglected and the fundamental task of building basic trust isn't achieved, a deep mistrust results. And that foundational flaw interferes with every single future developmental task.
So pulling our smartphone analogy back in, a personality disorder happens when you take an extreme biological temperament, say someone factory installed with incredibly low harm avoidance and extremely high novelty seeking.
Basically a thrill seeker with zero fear switch.
Right. And you pair that with disastrous environmental character development. Say they grew up in a profoundly abusive environment that completely failed to foster basic trust or cooperativeness.
Right, the corrupted software.
The combination of that extreme hardware and corrupted software produces a severely maladaptive, inflexible way of viewing the self, coping with the world, and relating to others. The system essentially crashes under the weight of everyday life.
That is the exact etiology of these ingrained patterns.
Yeah.
It is nature and nurture colliding in a way that creates extreme rigidity.
Okay, now that we understand the architectural blueprint of these disorders, we really need to focus on where you, the psychiatric nurse, are actually going to face them on the floor.
Yeah, where the rubber meets the road.
The DSM-5 outlines 10 distinct personality disorders divided into 3 clusters, A, B, and C. But for the acute psychiatric inpatient setting, we are hyper-focusing on 2 of them. Why are we leaving the other 8 for later?
Because of the acute care environment itself.
Well,
You will absolutely encounter all 10 types in community health clinics, general med-surg floors, or outpatient therapy. In the locked acute psychiatric hospital, your reality will be dominated by 2 diagnoses.
borderline personality disorder, or BPD, and antisocial personality disorder, or ASPD. The 80-20 rule in action, these are the big 2. But why? Why are these specific 2 so heavily tested on nursing exams and so incredibly prevalent on the inpatient unit?
It all comes down to safety, crisis, and lethality. People with the other personality disorders, like a schizoid patient who isolates, or an OCPD patient who is rigid at work, they usually avoid treatment altogether, or their symptoms are managed well enough in the community.
They aren't having life-threatening emergencies.
Exactly. They don't typically experience the acute psychiatric emergencies that require an inpatient admission. DPD and ASPD, however, land in the acute care setting due to severe explosive safety emergencies.
With borderline personality disorder, that hospitalization is almost always driven by profound emotional instability that has rapidly escalated into severe self-harm or active suicidality.
They are admitted because they are an immediate lethal danger to themselves.
And with antisocial personality disorder.
The admission is frequently involuntary. It might be part of a court-ordered psych evaluation, or it's being used by the patient as a calculated alternative to going to jail. Yeah, they're there because their behavior has drastically violated social or legal norms, and they pose a potential danger to others.
The contrast here is fascinating. I mean, you have 2 disorders that require completely opposing nursing models and therapeutic approaches,
Completely opposite.
but both of them will absolutely push a nurse to their breaking point. They both relentlessly test your ability to maintain incredibly strict personal and professional boundaries. They both manipulate the milieu, just using entirely different mechanisms.
Treating them is the ultimate test of your clinical objectivity. You have to stay grounded while the patient is doing everything in their power, consciously or unconsciously, to pull you into their chaos.
Okay, so let's dive into the first of the major acute care diagnoses. We're starting with the one that presents the highest immediate physical risk to the patient: borderline personality disorder, the razor's edge of safety. Walk me through the clinical picture.
BPD is characterized by a pervasive pattern of wildly unstable interpersonal relationships, a highly unstable self-image, and volatile affect, all combined with marked impulsivity.
And how common is this?
Epidemiologically, up to 3% of the general population has BPD. It is the single most common personality disorder you will find in clinical settings. And interestingly, it's diagnosed roughly 3 times more often in females than in males.
But let's dig into the why. What is the core pathophysiology? What is the engine driving this massive instability? Because, to a new nurse, it just looks like the patient is being dramatic or constantly seeking attention.
Right, and you have to look past the dramatic behavior to see the underlying terror. The core problem in BPD stems from intense, chronic fears of abandonment and a profound, agonizing intolerance of being alone.
It's that extreme.
It is so excessive, so deeply rooted in their psyche that it dictates their behavior, even in completely normal everyday situations.
Let's create a clinical scenario to see what this looks like on the floor. Let's say we admit a young woman named Sarah. If I am the nurse doing her admission assessment, what subjective and affective symptoms is Sarah going to report?
Sarah's pervasive mood is likely severely dysphoric. She experiences an intense unhappiness, a restless malaise that she just can't shake.
So she's just miserable all the time.
Yeah, and BPD patients will often report feeling a chronic, deep sense of emptiness. They describe it as a literal physical void inside them. They suffer from intense loneliness and boredom, and they rarely experience periods of genuine satisfaction or well-being.
But that depressed effect isn't flat, right? Like you see in major depressive disorder.
No, not at all. It is incredibly unstable and erratic.
Right, so Sarah might be sobbing one minute and then suddenly become intensely irritable, hostile, or sarcastically vicious toward the nursing staff.
Exactly. They experience extreme raw emotions like rage, but they do not have the internal tools or coping mechanisms to process or express those emotions productively.
And the triggers can seem incredibly minor to an outsider.
Oh, absolutely. If a therapist simply needs to reschedule an appointment by one day, to Sarah, that isn't a scheduling conflict. That is complete, devastating abandonment, and it can precipitate a severe emotional crisis.
And this fear of abandonment ties directly into their behavioral findings, most notably a deeply primitive defense mechanism called splitting.
Yes. This is a monumental concept for the NCLEX
Right.
and for surviving your clinical rotations.
Let's break down the psychology of splitting. How does it work?
Splitting is polarized, black and white, extreme thinking. It is the absolute inability to integrate the positive and negative qualities of a person into a cohesive image.
So there's no gray area.
Zero gray area.
Mm-hmm.
To a patient with BPD, you're either totally perfectly good or you are entirely maliciously bad.
Wow.
In relationships, this means Sarah might adore and idealize a nurse after a single 10-minute interaction. She might tell you that you are her savior, the only nurse in the hospital who truly understands her trauma, the best nurse she has ever had.
And honestly, as a new nurse, that feels great. Your ego gets stroked. You think, wow, I'm really making a breakthrough with this patient. I have a connection. But it is a trap.
Total trap.
Because the moment you have to enforce a unit rule, say, telling Sarah she can't have her phone after 10 p.m., or the moment you aren't immediately available because you're with another patient, the splitting flips.
It flips instantly and violently. You, the nurse, are completely devalued. You become the enemy. You are suddenly the worst, most abusive, completely uncaring nurse in the world.
And Sarah isn't faking this shift, is she?
No. In her mind, her reality has completely altered. This rapid, unpredictable shifting makes their interpersonal relationships incredibly stormy, intense, and frankly exhausting for everyone involved.
And because they hate being alone, but their erratic, hostile behavior inevitably isolates them and pushes people away. They engage in frantic, sometimes desperate behaviors to avoid that real or perceived abandonment.
Which brings us to the safety red flags. And in BPD, the safety risks are severe and immediate.
They are life-threatening. The clinical reality is that between 8 and 10% of people with BPD die by completed suicide.
That is a staggering mortality rate for a psychiatric disorder. But beyond completed suicide, the unit is frequently dealing with a massive prevalence of non-suicidal self-injury, or NSSI.
We're talking about deliberate self-harm, cutting their arms or thighs, burning themselves with cigarettes, violently punching themselves or walls.
Yes. Some of these patients suffer massive scarring or permanent disability, like paralysis from severing nerves or tendons during a cutting episode.
And to effectively care for them, you have to understand the psychology behind the self-mutilation. It is almost never just attention-seeking.
Right, which is a terrible stigmatizing term we really need to drop from our vocabulary.
Self-injury is typically a desperate cry for help, an expression of intense anger or helplessness, or a form of internal self-punishment.
But crucially, the physical pain is often utilized as a mechanism to block out emotional pain. Some clients report that they engage in self-mutilation simply to reinforce that they are still alive.
To feel something.
Exactly. They are seeking to experience grounded physical pain in the face of profound emotional numbing or severe dissociation.
Plus, under extreme stress, BPD patients can experience transient psychotic symptoms, like they might report auditory hallucinations that actually demand or encourage them to self-harm.
Which leads us directly to the absolute priority nursing assessment.
This is the crucial clinical scenario, the exact situation you will see on your exams. If Sarah is cutting herself on the unit and she tells you she's doing it just to feel alive or to block out the emotional pain of a breakup, how does a nurse differentiate that from a true legal suicide attempt?
Yeah, the NCLEX priority logic is crystal clear here. Physical safety is always the first priority. The nurse must always unequivocally seriously consider suicidal ideation with the presence of a plan, access to means, and self-harm behaviors.
So you always ask.
You must directly assess for a suicidal plan even if the patient has a 10-year history of non-lethal, superficial self-mutilation.
I really want to hammer this home for the listener. You can never, ever assume it is just their typical cutting behavior. You cannot get complacent. You must directly assess suicidal intent, ask if they want to die, and determine if they have a plan every single time an incident occurs.
Exactly. Clients with BPD often experience chronic, baseline suicidality over months or even years. The clinical challenge is determining when those chronic ideas are actively translating into lethal action. So never underestimate the suicidal risk by solely focusing on the superficial self-harm behaviors.
Okay, so let's pivot to nursing interventions and milieu management. How do we actually keep Sarah safe, and how do we manage the environment so her behavior doesn't destabilize the other 20 patients on the unit?
Structure and boundaries are your primary therapeutic tools. From a pure environmental safety perspective, you place the client in a room near the nursing station, or in an area where they can be observed easily and frequently.
You do not place them at the end of a long hallway near a secluded stairwell.
No, definitely not. And you closely, rigorously supervise their use of any sharp or potentially dangerous objects during meals or art therapy.
And regarding their behavior on the unit, the clinical guidelines suggest that the nurse should withdraw attention as much as possible if the client acts out, assuming the client's safety is not an immediate risk.
Right.
Now, to a lot of compassionate, newly minted nurses, that feels incredibly counterintuitive. If someone is screaming in the day room, our instinct is to rush in, soothe them, and comfort them.
It does feel counterintuitive, I know, but it is an essential behavioral intervention. Withdrawing attention decreases the acting out behaviors. Think about the operant conditioning at play here.
Okay.
If Sarah throws a massive temper tantrum in the hallway and suddenly gets the undivided, highly sympathetic attention of 3 nurses and a doctor, that acting out behavior has just been heavily reinforced.
She learned that screaming gets her needs met.
Exactly. You must be consistent, set firm behavioral limits, and maintain them neutrally.
Let's talk about therapeutic communication. What do we actually say and what do we categorically avoid? First, I want to talk about no-harm contracts because the guidance on this has shifted significantly over the years.
This is a major shift in modern psychiatric practice, and it's a highly testable exam point. Decades ago, it was standard practice to ask a BPD client to sign a physical no-harm contract,
where they promise the staff they won't engage in self-injury and they'll report to the nurse when they feel like losing control.
Right. But the current literature is definitive on this. There is zero empirical evidence to support the effectiveness of these contracts.
Why do they fail? I mean, it sounds like a good idea in theory.
Because for a BPD patient in the middle of a severe splitting episode, the self that signed the contract yesterday literally feels disconnected from the self that is currently drowning in emotional agony.
Oh, wow.
The contract relies on a stable sense of identity and impulse control, which is exactly what their pathology destroys.
Right. In fact, the literature warns that these contracts may give nursing staff a false, dangerous sense of security.
Absolutely. The clinical focus should instead shift to exploring the self-harm behavior when the client is completely calm. You help them retrospectively identify the trigger situations, the specific moods, or the interactions that preceded the self-injury.
So they can learn to implement more effective coping skills before the crisis peaks.
Exactly.
And if they do injure themselves, like if you walk into Sarah's room and find that she has just deeply scratched or cut her forearm with a piece of plastic,
You assess the injury, and you provide first aid or wound care in a highly calm, completely matter-of-fact manner.
you don't get flustered.
You do not get flustered, you do not lecture her, you do not chastise her. Being punitive has zero positive effect. It only increases her self-hatred and fuels the cycle.
In fact, you want to actively deflect attention from the physical act itself.
Right? Yes. You clean the wound, apply the bandage, and redirect the conversational focus to the underlying emotions that led to the act.
You also have to teach effective, basic communication skills. The literature emphasizes modeling rudimentary social skills, like maintaining appropriate eye contact, practicing active listening, and strictly using I statements.
Right. Like teaching them to say, I think, I feel, or I need, rather than accusing, you made me do this.
And you have to set incredibly strict professional boundaries.
The boundary setting is critical because their internal personal boundaries are completely blurred. They will try to blur the lines of the professional relationship to enmesh with you.
So if Sarah says, you're so much better than the doctors, you're the only one who really understands my trauma.
A therapeutic boundary setting response would be, I am interested in helping you get better, just as the rest of the treatment team is.
You immediately redirect her back to the team approach and the clinical goal, avoiding the trap of being idealized.
Exactly. You don't take the bait.
We also need to talk about cognitive restructuring interventions. Because their thinking patterns are so rigidly polarized into black and white, we have to teach them how to reshape those thoughts. We use 3 specific techniques: thought stopping, positive self-talk, and decatastrophizing.
Let's start with thought stopping.
Yeah.
It's a literal behavioral interrupt. When a cascade of negative or self-critical thought patterns begins, like Sarah spiraling into, I'm stupid, I ruin everything, everyone hates me, she is taught to forcefully say stop aloud.
Or to vividly visualize a bright red stop sign in her mind to temporarily short-circuit that neurological pattern.
Right. Next is positive self-talk, which is reframing the narrative.
So instead of the absolute statement, I completely ruined everything by getting angry, it's reframed to, I made a mistake in how I communicated, but it's not the end of the world. Next time I'll use my coping skills.
Exactly. And decatastrophizing is directly challenging their rigid, apocalyptic thinking.
When Sarah assumes the absolute worst is going to happen because her therapist was 5 minutes late, the nurse intervenes and asks, what is the actual worst thing that could happen? Or how likely do you realistically think it is that your therapist abandoned you?
It forces the cognitive brain to assess the situation realistically, overriding the emotional brain's default to catastrophe.
Finally, for BPD interventions, let's talk about structuring time. Why is having a written, rigid daily schedule so vital for these patients?
Because it directly combats that chronic, agonizing boredom and profound emptiness we discussed earlier. When BPD patients have long periods of unstructured time on the unit, they become highly ruminative.
They just get trapped in their own heads.
Yes, and they may engage in frantic, desperate behaviors just to change how they feel or to generate chaos for stimulation.
So a written schedule for daily activities, waking up, hygiene, group therapy, journaling time, walking, minimizes that unstructured void and gives them a predictable sense of control over their environment.
That's the goal.
Okay, so that is borderline personality disorder. The pathology is driven by terror, and the patient is directing their profound instability inward through self-harm, or projecting it intensely onto their immediate caregivers through splitting.
Right.
But what happens when you have a patient who directs their pathology entirely outward? When they actively, coldly manipulate the entire milieu, not out of a fear of abandonment, but purely for personal gain, profit, or amusement?
Then you are dealing with the second half of the acute care heavyweight division, antisocial personality disorder, or ASPD. the master manipulators.
ASPD is characterized by a pervasive, lifelong pattern of disregard for and violation of the basic rights of others. It is fundamentally driven by deceit, coercion, and manipulation.
You'll often hear this referred to in true crime podcasts or popular culture as psychopathy or sociopathy, though the formal clinical term you will see on the NCLEX is antisocial personality disorder.
Epidemiologically, it occurs in about 3% of the general population, but it accounts for up to 30% of the population in clinical psychiatric settings. And it is significantly more common in males.
And in prison populations, roughly 70% of incarcerated individuals meet the diagnostic criteria for ASPD.
That's huge. Let's talk about the risk factors and the patient history because the developmental timeline here is very specific, highly predictable, and heavily tested.
The clinical onset is almost always in childhood or early adolescence, even though a formal legal diagnosis of ASPD isn't made until the individual is at least 18 years old.
A childhood psychiatric history of conduct disorder is a major red flag, right?
Huge red flag. Specific childhood predictors include a history of enuresis, bedwetting, sleepwalking, and what the literature calls syntonic acts of cruelty.
Let's define syntonic acts of cruelty. This means they engage in cruelty, usually toward animals or smaller, weaker children, and it does not bother them in the slightest. It aligns perfectly with their ego.
Right. If a normal child hurts a family pet, they usually feel guilt or cry when reprimanded.
But the child developing ASPD feels nothing.
Exactly. In adolescence, this lack of empathy escalates to pathological lying, truancy, sexual promiscuity, early substance use, and illegal activities like theft or vandalism.
Interestingly, the natural history of the disorder shows that these overt antisocial and criminal behaviors tend to peak in the patient's 20s and actually diminish significantly after 45 years of age.
Yeah, they become less likely to engage in impulsive, overt criminal behavior that gets them arrested, though their fundamental cold disregard for others usually persists for life.
So what are the expected findings when you are assessing an adult with ASPD on the inpatient unit? Let's invent a patient named Marcus. He was brought in on a court order after an altercation at a bar. What is his behavioral presentation?
Superficially, Marcus is going to appear completely normal and highly intelligent. In fact, he can be incredibly engaging, articulate, and charming.
Master manipulators.
Exactly. These individuals are phenomenally skillful at deceiving others. Marcus will display false emotions perfectly tailored to suit the occasion or to work to his advantage.
Right, so Marcus might sit in the assessment room, look the nurse in the eye, and act terribly, profoundly sad about his abusive childhood if he calculates that generating sympathy will help him avoid jail time.
And secure a comfortable bed in a treatment facility instead. It is a total performance.
The actual internal emotions are completely shallow.
Yes. The defining characteristic is a total chilling lack of empathy. Marcus literally cannot empathize with the feelings or suffering of others, which is the exact mechanism that enables him to exploit people, steal from them, or assault them without a shred of internal guilt.
If he expresses remorse, it is usually only because he is facing consequences for getting caught breaking the rules.
Exactly. Cognitively, Marcus does not have disordered thoughts. He isn't hallucinating. He isn't psychotic. He likely has an average or above average IQ. But he operates with a highly distorted, incredibly narrow, predatory worldview.
His entire view of humanity is motivated by coercion and personal profit, and he naturally assumes everyone else operates the exact same way.
He views the world as a cold, hostile place where only the strong survive. ASPD patients routinely rationalize their predatory behavior with cliches like, "It's a dog-eat-dog world," or "Only the strong survive."
They genuinely believe they are only taking care of themselves because no one else will, and if someone gets exploited in the process, well, they deserved it for being weak.
Which brings up the massive safety red flags for the nursing staff. With Marcus on the unit, there's an incredibly high risk for physical violence, extreme impulsivity, substance abuse, and crucially, exploiting vulnerable patients on the psychiatric unit.
Oh, yeah. Marcus will scan the day room, spot the weakest, most disorganized schizophrenic patient, and manipulate them into giving up their food, their cigarettes, or their phone privileges.
Which leads us directly into the priority nursing assessment.
This is a really tricky exam scenario for students. Marcus looks normal, he sounds charming, he is highly intelligent, and he isn't psychotic. He isn't cutting himself like Sarah. What exactly is the nurse assessing?
You are primarily assessing for ineffective coping, the potential for imminent violence, and hidden substance use. But the most critical assessment technique with ASPD is external validation.
validating the information.
Yes, because Marcus is a master manipulator and a skillful liar, you must independently check and validate all information regarding his history from outside, objective sources. You read the police report, you talk to previous providers. You do not, under any circumstances, take his subjective history at face value.
And as for nerving interventions, the psychiatric literature explicitly states that the primary treatment focus for ASPD is behavioral change, not gaining insight. I really want to emphasize that. Why is insight-oriented therapy useless here?
Because they will almost never see their own actions as the root cause of their problems. It is always someone else's fault. The police officer was out to get them, the victim provoked them, the system is rigged.
They universally blame external sources.
So a nurse trying to sit down and coax Marcus into having deep, reflective, emotional insight into his character is a complete waste of therapeutic time. You focus entirely on changing the outward, observable behavior on the unit.
And how do we do that? We use the single most testable concept for ASPD, the holy trinity of limit setting.
Limit setting is the paramount nursing intervention. And to be effective, it must involve 3 strict, consistent, and sequentially delivered steps. Number 1, state the behavioral limit. You describe the unacceptable behavior clearly and objectively.
Number 2, identify the consequences if the limit is exceeded.
And number 3, identify the expected or desired behavior.
Let's give a concrete clinical example. Let's say Marcus approaches a new grad nurse in the hallway, acts very flirtatiously, and attempts to gain personal information about where she lives to try and compromise her boundaries.
The nurse must immediately implement the 3 steps in a flat, matter-of-fact tone. Marcus, it is not acceptable for you to ask me personal questions. If you continue to do so, I will terminate this interaction and you will lose your day room privileges. We need to use this time to focus on your discharge planning.
Limit stated, consequence stated, expected behavior stated. Boom! It leaves no room for negotiation. But there are major pitfalls here. What must the nurse avoid doing during this interaction?
You must avoid discussing why the rules exist. Do not get pulled into a philosophical debate with Marcus about fairness.
You just state the requirement matter-of-factly and avoid arguing.
Exactly. You also avoid trying to coax or convince him to do the right thing. You do not appeal to his sense of morality because he doesn't have one. You simply present the consequence, and he must decide to accept responsibility for his choices.
And most importantly, you do not react with visible anger, frustration, or in a punitive manner. If you show anger, you have lost.
The ASPD patient will exploit that emotional reaction. They have found your weak spot, and they will use it to claim that you are the aggressor.
The literature also highlights the therapeutic technique of confrontation. Now, in a clinical setting, this isn't about being aggressive or getting in the patient's face. It's about pointing out the stark incongruence between the client's stated intentions and their actual behavior.
You remain entirely neutral and objective. If Marcus says he desperately wants to get his anger under control so he can leave the hospital, but he skips group therapy every day to watch TV, you confront that discrepancy.
Marcus, you said you want to manage your anger to facilitate your discharge, but you have missed the last 3 anger management groups. You hold up a mirror to the present behavior, stripping away the manipulation.
Milieu safety and absolute staff consistency are also incredibly important here. Just like with BPD, ASPD patients are masters at splitting the staff. They will play the day shift against the night shift, trying to bend the rules just this once.
Oh, the night nurse let me have an extra snack. She actually cares about my nutrition. Why are you being so rigid?
Exactly. This is why all staff, from the doctors to the techs, must adhere rigidly to the written care plan. If Marcus finds even one single person willing to make independent changes or bend a rule, the entire treatment plan becomes ineffective.
You also want to teach the patient to utilize timeouts, recognizing their own rising frustration and leaving the area to go to a neutral place to regain internal control, avoiding an impulsive, aggressive outburst that will result in a consequence.
Yes, timeouts are a great tool for them to self-regulate.
Okay, so we have deeply explored the 2 most intense high-risk disorders in the acute setting. We've established that these personality traits are deeply ingrained hardware and software issues that cannot be fundamentally changed by a pill.
Right.
So let's talk pharmacology. If you can't medicate a personality, what exactly is a psychiatrist prescribing and what is the nurse monitoring? It sounds like giving someone cough syrup to treat a broken leg. What is the clinical logic here?
The clinical logic relies on the 80-20 rule for psychopharmacology in the context of personality disorders. You do not treat the disorder itself. You treat the target symptoms.
So you are utilizing medication to manage the specific symptomatic manifestations that are causing the most immediate distress or presenting the highest danger to the milieu.
It is essentially chemical management of the crisis.
The psychiatric guidelines divide these target symptoms into 4 specific categories: aggression, mood dysregulation, anxiety, and psychotic symptoms. Let's run through the must-know medication classes for each, starting with aggression and impulsivity. If Marcus is throwing chairs, what are we giving him?
For severe aggression and dangerous impulsivity, the primary drug choices include mood stabilizers like lithium, anticonvulsants such as valproate or Depakote, and low-dose antipsychotics like haloperidol or Haldol.
The underlying theory is that these medications blunt the neurochemical spikes that drive predatory aggression or explosive organic-like impulsivity.
They lower the baseline volatility.
What about mood dysregulation? This includes the wild, volatile emotional instability we see in a borderline patient like Sarah, or the severe emotional detachment we might see in other disorders.
For severe emotional lability and rapid mood swings, providers rely again on lithium, carbamazepine, which is Tegretol valproate, or low-dose neuroleptics.
Interestingly, if the target symptom is severe emotional detachment, a patient exhibiting cold, aloof, totally withdrawn behavior, the provider might utilize SSRIs or atypical antipsychotics like risperidone or olanzapine to help activate them.
Atypical depression or intense dysphoria often responds well to SSRIs or MAOIs.
Moving to anxiety, the chronic cognitive worry or somatic anxiety that paralyzes some of these patients.
Standard antidepressants, specifically SSRIs and MAOIs, are the mainstays here for long-term management of chronic anxiety and personality disorders.
And finally, cognitive perceptual distortions, which the literature describes as low-grade psychotic-like symptoms. The magical thinking, the severe suspiciousness, the auditory whispers.
Those chronic, low-grade perceptual distortions usually respond favorably to low-dose antipsychotic medications, which help organize their thinking without the heavy sedation required for acute schizophrenia.
Okay, now for the most important part of this section: the safety red flags and exam logic. There's a massive glaring contraindication in the pharmacological management of personality disorders regarding one very specific class of medications.
Benzodiazepines. The clinical guidelines emphatically state that benzodiazepines should be categorically avoided in patients with borderline or antisocial personality disorders.
Why? I mean, think about the mechanism of action. Benzodiazepines like lorazepam, alprazolam, or diazepam work on the GABA receptors to depress the central nervous system and lower inhibition.
Right, so if you give a benzo to a patient who already struggles with severe impulsivity, aggressive tendencies, and a high likelihood of substance abuse, you're essentially throwing gasoline on a fire.
The potential for misuse, chemical dependence, and lethal overdose is incredibly high in this population.
But more dangerously, in patients with severe cluster B personality disorders, benzos can actually cause paradoxical disinhibition.
Wow, so instead of calming them down, the medication removes their already fragile impulse control, making the patient significantly more impulsive, more violent, and more aggressive.
Exactly.
So listener, lock this away for your clinical judgment and your NCLEX exams. This is a classic prioritization question. If you see a PRN order for a benzodiazepine for an ASPD patient with a history of substance abuse or violence, that is your immediate cue to stop.
You do not administer the medication. You question that order with the provider. It is a major life-threatening red flag.
Absolutely. The risk of paradoxical rage or overdose far outweighs the temporary anxiety relief.
100%.
So we have locked down the highest yield acute care material. We've covered the big 2, the safety risks, the communication, and the pharmacology. But we need to quickly map out the rest of the personality disorder landscape.
Because while these patients might not be admitted to the psychiatric unit specifically for these traits, you will absolutely see them everywhere else.
These disorders show up in every single area of healthcare. You will treat these patients in the ER, in the maternity ward, in the ICU, in oncology.
They will be admitted for a routine medical issue like a gallbladder removal or a broken hip. But their underlying personality disorder will severely complicate the care plan, baffle the medical staff, and really test your patients.
Let's start with Cluster A, the odd or eccentric behaviors. This cluster includes paranoid, schizoid, and schizotypal personality disorders. Let's hit the expected findings and the exact nursing priorities for each. First, paranoid personality disorder.
Paranoid personality disorder is characterized by a pervasive, unwarranted mistrust and suspiciousness of everyone. They interpret the benign actions of others as potentially harmful or malicious.
They heavily utilize the defense mechanism of projection, constantly blaming other people, the government, or institutions for their own difficulties.
They are deeply guarded, hypervigilant, and have a very restricted cold affect.
Imagine a patient admitted for pneumonia who refuses their AVI antibiotics because they are convinced the nursing staff is secretly testing experimental drugs on them. What is the nursing priority when dealing with this paranoia?
You must approach them in a highly formal, strictly businesslike manner. Do not try to be their best friend.
Refrain from social chit-chat or casual jokes because they take everything completely seriously and will obsessively analyze your motives to find the hidden threat.
Involve them heavily in their care planning so they feel a sense of control over their environment, and therapeutically help them logically validate their ideas before taking action, which helps prevent them from acting impulsively on their paranoid beliefs.
Next in Cluster A is Schizoid personality disorder.
Schizoid is characterized by a pervasive pattern of profound detachment from social relationships. They have a severely restricted range of emotional expression. They are aloof, totally indifferent to praise or criticism, and appear emotionally cold to the point of being robotic.
They strongly prefer interacting with things like computers, complex puzzles, or machinery over people. They have absolutely zero desire for friends, intimacy, or sexual relationships.
Let's say you are a community health nurse managing a schizoid patient. What is the clinical priority?
The focus is entirely on improving their practical functioning in the community without forcing unwanted socialization. If they need housing, you find them a facility that accommodates their intense need for solitude, like a quiet board and care home that provides meals but requires little to no social interaction.
Do not, under any circumstances, force them into group therapy or highly social situations. It will not cure their isolation. It will only increase their distress and cause them to withdraw further.
And the last one in Cluster A, Schizotypal personality disorder.
Schizotypal is marked by acute discomfort in relationships, combined with severe cognitive or perceptual distortions and behavioral eccentricities. They might have a highly odd, unkempt appearance. Their speech might be vague, metaphorical, or outright bizarre.
They frequently experience magical thinking, genuinely believing their thoughts have special powers to influence events, or believing in telepathy.
The classic example of their bizarre speech pattern. If a nurse asks a schizotypal patient how they slept, instead of saying fine, they might stare at the wall and say, "Sleep is slow. The REMs don't flow in the cosmic river."
Right, and they experience immense, paralyzing social anxiety around other people. Unlike normal anxiety, which might decrease as you get to know someone, schizotypal anxiety does not improve with time because it is rooted in a fundamental paranoid belief that strangers simply cannot be trusted.
So what is the nursing priority for a schizotypal patient?
Developing rudimentary self-care skills and improving their ability to survive in the community. You help them establish a rigid daily routine for basic hygiene and grooming.
Because face-to-face contact causes such severe anxiety, you might help them practice making written requests or using the phone to conduct personal business, like paying rent or ordering groceries.
You role-play basic, brief interactions with clerks or landlords so they can function independently without triggering a panic attack.
Okay, moving to cluster B erratic or dramatic behaviors. We already covered BPD and ASPD extensively, but there are two more heavy hitters in this group: histrionic and narcissistic personality disorders.
Let's look at histrionic first.
Histrionic personality disorder is characterized by a pervasive pattern of excessive emotionality and relentless attention-seeking. They are colorful, highly theatrical, and often dressed provocatively.
But their emotions are incredibly shallow and shift rapidly. They experience intense physical discomfort when they are not the center of attention, and they will go to massive dramatic lengths to get that attention back, fabricating elaborate stories, creating public scenes, or even physically fainting in the hallway.
They also severely exaggerate the intimacy of relationships. A histrionic patient might call an acquaintance they met yesterday their dear, dear soulmate, or claim a doctor who spent 2 minutes in their room is the most brilliant, wonderful doctor in the entire world. We have such a special connection.
The nursing priority here revolves entirely around teaching appropriate social boundaries and providing factual feedback.
If a histrionic patient becomes overly affectionate or invades your personal space, you must state clearly and neutrally. It is more appropriate to stand 2 feet away and shake hands when greeting someone.
You role-play active listening, teaching them to focus on others rather than constantly redirecting the conversation back to their own drama.
And then we have narcissistic personality disorder.
Narcissistic is defined by pervasive grandiosity, an insatiable need for admiration, and a profound lack of empathy. They genuinely believe they are superior, special, and uniquely privileged.
However, their underlying self-esteem is actually incredibly fragile, making them violently hypersensitive to any form of criticism or perceived slight. They display a massive sense of entitlement and will coldly exploit relationships to elevate their own status.
This one is a major challenge for medical surgical nurses. The red flag here is their behavior toward the nursing staff. If a narcissistic patient is admitted for a cardiac issue, they will often be intensely arrogant, haughty, rude, and hypercritical of your care.
They will demand the chief of medicine and act like the hospital rules regarding visiting hours do not apply to them.
The primary nursing priority here is managing your own internal reaction. You must use a calm, strictly matter-of-fact approach to gain their cooperation with medical treatments. You set firm limits on verbally abusive behavior.
But crucially, you must not internalize their criticism. When they tell you that you are an incompetent nurse because you brought the wrong brand of juice, you have to recognize that this is a symptom of their fragile ego, not a reflection of your clinical skills.
If you take their insults personally and get defensive, you lose your therapeutic objectivity.
All right, let's look at the final cluster. Cluster C, anxious or fearful behaviors. This includes avoidant, dependent, and obsessive-compulsive personality disorders. Let's start with avoidant personality disorder.
Avoidant is characterized by extreme social discomfort, incredibly low self-esteem, and hypersensitivity to negative evaluation. They are timid, fearful, and easily devastated by even the mildest perceived criticism.
Now, here is a key NCLEX distinction. How is avoidant personality disorder different from schizoid personality disorder? Both patients isolate themselves and avoid social interaction. How do you tell them apart?
The crucial diagnostic difference is the desire for relationships. The schizoid patient isolates because they have absolutely no desire for human connection. They genuinely prefer to be left alone.
The avoidant patient, on the other hand, strongly, desperately desires social acceptance and intimacy, but they are terrified of rejection and humiliation. They avoid relationships entirely out of fear, not a lack of interest. They are painfully lonely.
The nursing priority for an avoidant patient.
Providing immense support, reassurance, and extreme patience. You help them practice self-affirmations and positive self-talk to slowly build their shattered self-esteem. You teach and practice social skills in a very safe, highly controlled, non-threatening environment before expecting them to interact with a larger group.
Next is dependent personality disorder.
This is characterized by an excessive, paralyzing need to be taken care of, leading to submissive, clinging behavior and intense fears of separation. They genuinely believe they will fail or die if left on their own.
They cannot make even the simplest decisions, from what job to take down to what color shirt to wear, without repeated advice and massive reassurance from others.
They will tolerate almost anything, even severe domestic abuse, to avoid losing a relationship.
The nursing priority and the exam logic here are very clear. Foster self-reliance. What is the one thing a nurse must never do for a dependent patient?
You must never, ever make decisions for them or give them advice on personal problems, even if they're crying and desperately begging you to tell them what to do.
Because doing so only reinforces their pathological helplessness.
Exactly. It feels mean to refuse them, but giving advice stunts their progress. Instead, you teach problem-solving and decision-making skills. You help them explore the pros and cons of different alternatives, but you force them to make the final choice themselves. And then you provide immense positive feedback for their effort to build their confidence.
Finally, the last disorder in Cluster C, Obsessive-Compulsive Personality Disorder, or OCPD.
OCPD is a pervasive preoccupation with perfectionism, mental and interpersonal control, and extreme orderliness. It comes at the complete expense of flexibility, openness, and efficiency. They are obsessed with details, rules, lists, and rigid schedules.
They strive for a level of perfection that is completely unattainable, which often means they miss critical deadlines or never actually complete a project because they are constantly checking, rechecking, and finding flaws.
Now, let's look at the exam logic here. The NCLEX loves to test the difference between OCD obsessive-compulsive disorder and OCPD obsessive-compulsive personality disorder. What is the fundamental clinical difference?
OCD is a clinical anxiety disorder characterized by true intrusive obsessions, like a fear of germs, and severe ritualistic compulsions, like washing hands 50 times, performed strictly to relieve profound anxiety.
OCPD is a rigid personality style, Patients with OCPD do not have classic intrusive obsessions or rituals. They just have an overwhelming egocentric need for order, control, and perfection in their daily lives.
They are harsh, highly critical of others, and have immense difficulty delegating tasks or working collaboratively because they believe no one else can do it perfectly. I've heard stories of nurse managers with OCPD who rewrite the unit schedule so many times trying to make it perfect that they forget to actually eat lunch.
The nursing priority for OCPD.
Encourage negotiation and flexibility. Help them set hard, non-negotiable deadlines for projects rather than allowing them to endlessly strive for unattainable perfection. Use cognitive restructuring to ask, what is the worst that could realistically happen if this report isn't 100% perfect? To challenge their inflexible thinking.
If we pull all of this together and connect it to the bigger picture, these clusters show just how incredibly diverse the human coping mechanism can be. From the bizarre magical thinking of the schizotypal patient to the grueling extreme perfectionism of the OCPD patient. But the common thread running through every single one of them is rigidity. The operating system is inflexible.
And that profound rigidity is exactly what brings them into constant conflict with the world, destroys their relationships, and eventually lands them in the healthcare system. Which brings us to our final and perhaps most important topic today, the nurse's mental health, self-awareness, and milieu survival.
Because dealing with this kind of intense, unyielding rigidity for 12 hours a day, 3 days a week, will absolutely test your mental, emotional, and physical limits.
Let's talk about the unspoken clinical skill, protecting your own mind from burnout.
The psychological toll of working with personality disorders cannot be overstated. The psychiatric literature addresses this directly because it is a massive cause of nursing turnover. Because these patients, especially those with ASPD or BPD, often look physically healthy and their intelligence is completely intact, it is incredibly easy for a tired nurse to fall into a dangerous cognitive trap.
The trap of thinking they just lack motivation or they're just being difficult on purpose. They could stop acting like this if they really wanted to.
Right. Unlike a patient who is acutely psychotic, responding to internal stimuli and hallucinating, or a patient who is catatonic with severe depression, the patient with a personality disorder looks entirely capable of functioning normally.
So when Sarah violently sabotages her treatment plan by cutting herself, or when Marcus hurls vile insults at you, it feels intentional, feels malicious.
You're driving home after a brutal 12-hour shift, and you are just angry. It feels deeply personal when a narcissistic patient belittles your nursing skills in front of the doctors, or when a borderline patient violently rejects the coping strategies you just spent 2 hours patiently teaching them.
That leads to immense frustration, anger, and eventually complete clinical burnout. You start hating your job.
This is why the literature emphasizes team consistency, not just for the patient, but as an actual, literal clinical intervention for the staff. We talked earlier about splitting, how ASPC and BPD patients will manipulate the team, playing one nurse against another, causing staff to disagree or contradict one another regarding limits.
They will scan the unit, find the nurse who's exhausted, or the new grad nurse who wants to be the cool nurse, and they will exploit them to create chaos among the staff.
And the only defense against that is ongoing, frequent, brutally honest communication with your colleagues. The exam and practice logic here is that discussing your feelings of frustration, anger, or inadequacy with your peers is a required part of the job. It is not a sign of weakness. It is how you maintain professional objectivity.
If you try to internalize it all yourself, you will lose your therapeutic distance and become ineffective. You have to step back, go into the break room, talk to your charge nurse, talk to the treatment team, and cognitively reframe the interaction. It is not me. This is the pathology of the disorder. This is the hardware crashing.
And you have to set incredibly realistic, small goals. Remember, restructuring a personality takes years. If your goal is to fix them by the end of your shift, you are setting yourself up for failure. If your goal is simply to keep them physically safe and maintain the boundary for 12 hours, you succeed.
Exactly. Knowledge is most valuable when it is applied under pressure. Remember the 80-20 rule we've discussed today. Prioritize physical safety above all else, always assess for lethality, adhere rigidly to your limit setting, and fiercely maintain your professional boundaries.
So, bring it all together. We have decoded the critical difference between treatable, acute psychiatric illness and deeply ingrained personality traits. We've mastered the critical safety priorities of borderline and antisocial personality disorders, the self-harm, the manipulation, the splitting.
We've built a solid, actionable blueprint for the holy trinity of limit setting. We've navigated the pharmacological red flags, especially avoiding those highly lethal benzos, and we've mapped out the entire landscape of the other clusters.
You, the listener, are now armed with the exact clinical logic needed to dominate this topic on your exams and safely manage these patients on the floor. You have the theoretical tools and the practical language to provide safe, effective care while also protecting your own professional and emotional well-being.
I want to leave you with one final, broader societal question to mull over as you digest all of this. We've spent this entire time talking about how we classify these extreme traits as disorders when they cause significant functional impairment or distress. But think about the world outside the locked hospital unit.
Think about the high-stakes corporate world or elite academia or national politics.
Are there environments where narcissistic grandiosity, antisocial ruthlessness, and lack of empathy or obsessive-compulsive perfectionism are not just tolerated, but are actually rewarded and highly celebrated?
Does the line between a clinical disorder and a distinct competitive advantage begin to blur depending entirely on the room you're sitting in?
It is a fascinating, slightly terrifying lens through which to view human behavior in modern society. I encourage you to observe the personalities in your own life, the people you work with, the leaders you see on the news through this new clinical perspective. Thank you for taking this deep dive with us into the demanding, chaotic, but ultimately fascinating world of psychiatric nursing. Trust your assessments, hold your boundaries, and stay safe out there.